Okay, everyone, we'll go ahead and get started. I would like to welcome Maureen Wolf, PhD, RDN, LD. She will be presenting on the topic current pediatric nutrition recommendations and dietitian linkages. Just a reminder that if you did call in, to mute your line so you don't hear too much feedback. Also, if you have any questions throughout the presentation, you can feel free to write it in the chat box, and I'll read them off at the end of the presentation. So with that, I'll turn it over to Maureen.
Thank you so much for the introduction. Can you all still hear me okay?
Yes.
Great, thank you. So I'm very glad to be with you all today and discuss current pediatric nutrition recommendations and dietitian linkages. So by the end of the presentation, I hope that you'll be able to describe current recommendations for pediatric nutrition relative to childhood obesity, access resources available for healthcare providers to support families in making lifestyle behavior changes, and also to identify opportunities and tools for connecting with registered dietitian nutritionists, or RDN. Today we'll first begin by discussing general pediatric nutrition recommendations as well as recommendations specific to childhood obesity. And then we'll talk about tools and resources to put the recommendations into practice. And then finally, again, how to connect and collaborate with registered dietitian nutritionists. Throughout childhood, we have a few key nutrition goals. First and foremost is to support optimal growth, development, and health. We also know that we want to establish healthy eating and physical activity behaviors that prevent immediate health concerns, whether that's iron deficiency anemia, undernutrition, eating disorders, dental caries, and obesity, as we're talking about as well. Similarly, we also want to promote lifelong behaviors that prevent chronic disease, such as type 2 diabetes, heart disease, cancer, and adult obesity. Finally, and also very important, we want to foster the development of competent eaters who feel positively about eating, they're reliable in feeding themselves and enjoy the food that they eat, and also listen to their body's internal cues for hunger and fullness. So really, overall, we want children to be able to experience food and nutrition in a positive way that helps support their lives both now and in the future. With those goals in mind, let's first start by talking about some of the overarching pediatric nutrition recommendations that are out there. So at the core of nutrition recommendations are the dietary reference intakes, or DRIs, which are important for understanding nutrient needs to support adequate growth and development in children. And these have been around for decades, and they've been issued through and established by consensus committees of the Institute of Medicine, which is now the National Academies of Sciences, Engineering, and Medicine. And so for each nutrient, whether that's vitamins, minerals, water, electrolytes, carbohydrate, and protein that are deemed essential, the DRI committees review the scientific literature to help inform nutrition standards for adequacy as well as toxicity for groups of people of different genders and at different life stages. Professionals and scientists, we can use the dietary reference intakes to plan and assess nutrient intakes of individuals. Yet we know that individuals eat food as opposed to nutrients in isolation. So we really need to have ways to communicate about how to meet these nutrient needs through food. And so one of the tools that help us begin this communication is the Dietary Guidelines for Americans. So the dietary guidelines translate science into more succinct food-based guidance that can be used to help individuals choose foods that provide a healthy and enjoyable diet. So the recommendations ultimately are intended to help individuals improve and maintain overall health and also reduce the risk of chronic disease. So really, the focus of the dietary guidelines is disease prevention. Although regardless of an individual's current health status, almost all people in the United States could benefit from shifting to choices to better support healthy eating patterns. So therefore, the dietary guidelines may be used or adapted by healthcare providers to encourage healthy eating patterns to patients and their families. The main purpose of the dietary guidelines is actually to inform the development of federal food and nutrition and health policies and programs. So the primary audiences are policymakers as well as nutrition and health professionals, and not necessarily the general public. So the dietary guidelines serves as the evidence-based foundation for nutrition education materials that are developed by the federal government to be used with the public. So for example, the federal dietary guidance publications are required by law to be consistent with the dietary guidelines. And those are also used to inform a variety of different programs such as the USDA's National School Lunch Program and School Breakfast Program, as well as the Special Supplemental Nutrition Program for Women, Infants, and Children, or WIC, which uses the dietary guidelines as the scientific basis for its food packages and also nutrition education programs. So a new edition of the dietary guidelines is published every 5 years to reflect advancements in scientific knowledge and also to translate science current at the time into sound food-based guidance to promote health in the U.S. The dietary guidelines currently provide recommendations for individuals 2 years of age and older. However, the next edition of the dietary guidelines is set to be released next year in 2020, and for the first time will actually include dietary guidance for infants and toddlers from birth to 24 months, as well as women who are pregnant. So that's really exciting, and we'll be looking forward to seeing that come out next year. So the 2015 to 2020 dietary guidelines is built around 5 guidelines that also have supporting key recommendations providing additional detail on the elements of healthy eating patterns. The key recommendations represent the predominant scientific evidence right now, and emphasis is really placed on topics with the strongest evidence and public health needs. So the 5 overarching guidelines include the following: follow a healthy eating pattern across the lifespan, focus on variety, nutrient density, and amount, limit calories from added sugars and saturated fats, and reduce sodium intake, shift to healthier food and beverage choices, and finally, support healthy eating patterns for all. So according to the dietary guidelines, a healthy eating pattern includes the following. So a variety of vegetables from all of the different subgroups, whether that's dark green, red, and orange, legumes, or starchy vegetables, fruits, especially whole fruits, but that may include fresh, canned, dried, or frozen, grains, at least half of which are whole grains, and when individuals choose refined grains, they should be enriched. Fat-free or low-fat dairy, including milk, yogurt, cheese, and fortified soy beverages. A variety of protein foods, including seafood, lean meats and poultry, eggs, legumes, as well as nuts, seeds, and soy products. And then finally, oils, including canola, corn, olives, peanut, safflower, soybean, and sunflower oils, as well as foods in which oils are naturally present. So again, nuts, seeds, seafood, olives, avocados, for example. The dietary guidelines also mention that a healthy eating pattern limits saturated fat and trans fat, as well as added sugar and sodium. And the dietary guidelines outline specific recommendations related to these that we'll review in just a moment. The current dietary guidelines also have an emphasis on shifts in food and beverage choices, suggesting that most Americans would benefit from shifting food choices both within and across food groups, and from current food choices to more nutrient-dense choices. Some simple examples include increasing vegetables and mixed dishes, while also decreasing the amounts of refined grains or meats high in saturated fat and or sodium, and also choosing beverages with no added sugars, such as water. With regards to supporting healthy eating patterns for all, each of us really has an important role to play in this aspect. So we know that there are a multitude of choices, messages, individual resources, and other factors that affect food and physical activity choices that an individual makes, and these decisions are rarely made in isolation. So the current literature has described a number of specific circumstances that can limit an individual's or a family's capacity to choose a healthy diet. And so these contextual factors For instance, food access, household food insecurity, and acculturation are particularly important for millions of people here in the United States. And so as appropriate as health professionals, we should consider these critical factors when developing strategies and providing education to our patients and their families. So overall, it's important to note that there really is no one type of healthy eating pattern, and the current dietary guidelines really embody the idea that a healthy eating pattern is not a rigid prescription, but really it's an adaptable framework where children and families can enjoy foods that meet their personal, cultural, and traditional preferences, and also, very important, fit within their budget. So now let's look more closely at some of the specific daily nutritional goals for children based on the GRIs and the dietary guidelines. Estimated energy needs for young children range from 1,000 to 2,000 calories per day, and for older children and adolescents, it really varies substantially from, say, 1,400 to 3,200 calories per day, with boys generally having higher calorie needs than girls. Total energy intake or total energy needs can vary greatly depending on physical activity level. And so there are more specific equations for estimating energy needs, but these values provide an example of the range. This table focuses on the macronutrients and identifies recommended dietary allowances, or RDAs, for protein and carbohydrates. And RDAs represent the average daily level of intake sufficient to meet the nutrient needs for nearly all healthy people, so about 97 to 98% of all individuals. And so also shown here are the acceptable macronutrient distribution ranges, or AMDRs, which are the percent of calories in the diet coming from carbohydrate, protein, and fat. And this is a range of intake for a particular energy source that's associated with reduced risk of chronic disease, while also providing intakes of essential nutrients. So the AMDRs for all age groups are really the same for the distribution of calories, with the exception of the 1 to 3-year-old age group that you can see here, when the recommendation for calories coming from fat is a little bit higher based on the developmental needs during that life stage. However, for the rest of the individuals, children, adolescents, and adults too, the general recommendations are for 10 to 30% of calories to come from protein, 45 to 65% of calories from carbohydrate, and 25 to 35% of calories from fat. With regards to dietary fiber, the overarching recommendation for all individuals, including children and adults, is 14 grams per 1,000 calories. So the recommendations you see listed here are based on those specific calorie levels that were assessed. And dietary fiber is one of the main nutrients that is underconsumed by many Americans, in addition to a few other vitamins and minerals that we'll talk about in just a moment. As I mentioned previously, the dietary guidelines also places emphasis on reducing added sugar and saturated fat. And so for both of these, the recommendation is to consume less than 10% of calories per day from each of the categories. Now let's look a little bit more at a few highlighted micronutrients. There are many more dietary reference intakes for micronutrients than what are shown here, but these represent some of the key vitamins and minerals that are underconsumed by many individuals in the U.S. These include potassium, magnesium, calcium, as well as vitamins A, D, E, and C. Iron is also underconsumed by most frequently adolescent girls. Low intakes for most of these nutrients occur within the context of unhealthy overall eating patterns due to low intakes of the food groups, usually vegetables, fruits, whole grains, and dairy that tend to contain these nutrients. So shifting to increase the intakes of these food groups can move the intakes of underconsumed nutrients closer to what's recommended. Of the underconsumed nutrients, calcium, potassium, dietary fiber, and vitamin D are considered nutrients of public health concern because the low intakes are associated with overall health concerns. And so for young children, women capable of becoming pregnant, and women who are pregnant, low intake of iron is also a public health concern. On the other end of the spectrum, many individuals overconsume sodium, and the dietary guidelines recommend consuming less sodium in the diet overall. So Americans are encouraged to follow the age and sex-appropriate tolerable upper intake levels, or ULs, for sodium. For individuals ages 14 years and older, that recommendation is 2,300 milligrams per day or less. And for children younger than 14 years of age, it varies between 1,500 and 2,200 milligrams per day, depending on the age. The dietary guidelines is developed and written for a professional audience, as I mentioned, and therefore finding ways to translate it into more actionable consumer messages and resources is really crucial to help children and families achieve healthier eating patterns. And so My Plate is the educational tool that helps communicate all of this evidence. The My Plate symbol and its supporting resources available at choosemyplate.gov bring together these key elements of healthy eating patterns and translate the dietary guidelines into, as I mentioned, more actionable messages. And so the key messages include: make half your plate fruits and vegetables, make half your grains whole grains, move to low-fat or fat-free milk or yogurt, and vary your protein routine. Additional key messages relative to fruits and vegetables include focus on whole fruits and also to vary your veggies, as I mentioned previously, trying to get vegetables from a variety of the different subgroups, and so really just trying to get more color in the diet overall. So based on the dietary guidelines, My Plate gives specific recommendations for amounts of food from each food group. These recommendations are designed to help individuals meet energy and nutrient needs in a more practical and relevant way. And so for children and adolescents, their recommendations vary by age and sex. And so I'll just briefly cover the ranges for the different groups here. So for fruit, 1 to 2 cups per day, 1 to 3 cups of vegetables per day, 3 to 8 ounce equivalents of grains per day, 2 to 6.5 ounce equivalents of protein per day, 2 to 3 cups of dairy per day, and also 3 to 6 teaspoons of oil per day. And so within each food group, the cup and ounce equivalents are shown here. So for instance, with vegetables, half a cup of raw or vegetables such as green beans would be equivalent to a half a cup of vegetables in this category, while 1 cup of raw or fresh greens such as spinach or lettuce would be equivalent to a half a cup, or 2 cups of lettuce would be equivalent to a 1 cup portion of vegetables. With fruit, again, fresh or raw, a half a cup is equivalent to a half a cup, and then a 1/4 cup of dry fruit such as raisins would be equivalent to 1/2 cup. Grains is presented a little bit differently in terms of ounce equivalents. So for example, 1 slice of bread would be equal to 1 ounce equivalent of grains, and then a half a cup of cooked brown rice would be equivalent to 1 ounce of grains. Dairy, probably most familiar with 1 cup of milk being a serving, and that is the case here. Also 6 ounces of yogurt would be equal to 3/4 cup, and 1.5 ounces of cheese would be equal to 1 cup or serving of dairy. With protein, this is also an ounce equivalent. So some examples, 1 large egg is equal to 1 ounce, 2 tablespoons of peanut butter is equal to 2 ounce equivalents, an ounce of nuts such as walnuts would be 2 ounces, half a cup of black beans would be equal to 2 ounces, and then for meat, it's equivalent on an ounce-by-ounce basis. So as shown here, 4 ounces of pork would be equal to 4 ounces of protein food. So some common areas and messages that you may be familiar with hearing, particularly around fruits and vegetables and dairy. So if a half a cup of fruit or vegetable is equal to 1 serving, then most children should be eating 5 or more servings per day. 5 to 9 servings a day is another common message. And then for dairy, the typical message is 3 servings per day. And for many children and adolescents, this is the case based on the recommendation. So with these recommendations in mind, we can look at what we're actually eating in the United States and see that the typical eating patterns currently consumed by many don't align with the dietary guidelines. And so this figure here provides a snapshot of those current intakes compared to the recommendations for the food groups, as well as added sugar and saturated fat and sodium. So the center line shown is the goal or the limit, and the bar represents the percent of the U.S. population ages 1 or older who are below, at, or above each dietary goal or limit. And so in short, the orange bars represent the percent of Americans who are not meeting the recommendation and show areas with room for improvement. And so when compared to the healthy U.S.-style eating pattern recommended in the dietary guidelines, about 3/4 of the population has an eating pattern that's low in vegetables, fruits, dairy, and oils. More than half of the population is meeting or exceeding total grain and total protein foods, and most Americans exceed the recommendations for added sugar and saturated fats and sodium. So now we can look at the intakes of vegetables across the different age groups in comparison to the recommended levels, and overall see that they are low as well. And so again, the blue bar represents the range of the recommended intake for vegetables, and the orange dot indicates the current intakes of vegetables. And so broadly, we know that 93% of children and adolescents don't eat enough vegetables. And vegetable consumption relative to the recommendation is lowest among boys ages 9 to 13 years and girls ages 14 to 18 years. We can look at fruits as well. We know that children ages 1 to 8 actually differ from the rest of the population in that many of them do meet the recommended intakes for total fruits, although average intakes for fruits are lowest among girls ages 14 to 18. Overall, we know that 60% of children and adolescents don't eat enough fruit. In terms of dairy, the average dairy intake for most young children ages 1 to 3 years meets the recommended amount, but all other age groups have average intakes that are below recommendation. And an age-related decline in dairy intake begins in childhood and persists at low levels for adults of all ages. Added sugars account on average for almost 270 calories and more than 13% of calories per day in the U.S. population. And so as you can see in the figure here, intakes as a percent of calories are particularly high among children, adolescents, and young adults in comparison to adults. And so when we look at the major sources of added sugars, typical in the U.S., the majority is coming from beverages, which include soft drinks, fruit drinks, sweetened coffee and tea, energy drinks, and also flavored waters. And beverages account for almost half, 47%, of all added sugar consumed by the U.S. population. So now that we've discussed nutrition recommendations for all children, let's look a little bit more closely at the evidence-based recommendations with regard to childhood obesity. And so we'll focus on 2 main sets of recommendations, those from the 2007 Expert Committee report, as well as those from the Academy of Nutrition and Dietetics Pediatric Weight Management Guidelines, and then think about how they fit in with overall nutrition recommendations that we've already discussed. The 2007 Expert Committee developed recommendations for assessment, prevention, and treatment of childhood obesity. The recommendations, as many of you likely know, include screening for body mass index or BMI of all children 2 years of age and older, as well as assessing medical risk at the level of the child and the family, behavior risk such as sedentary time, eating, and physical activity behaviors, and then also attitudes of the family and the patient with regards to their concerns and motivation. So prevention is recommended for children with a BMI less than the 85th percentile, and the staged treatment approach is recommended for children with a BMI at the 85th percentile and above for overweight and obesity. The recommendation cites that the primary goal of obesity treatment is improvement of long-term physical health through permanent healthy lifestyle habits. And so today in this webinar, we're going to focus on prevention as well as stages 1 and 2, since those are recommended to occur in primary care settings with a primary care provider and or trained professional staff members such as a nurse or a registered dietitian. With regards to prevention of childhood obesity, the expert committee recommended that healthcare providers encourage patients and their families to adopt and maintain the following specific eating behaviors based on the evidence. So first, limiting consumption of sugar-sweetened beverages, encouraging consumption of diets with recommended quantities of fruits and vegetables based on those recommendations from the USDA and that we talked about with My Plate, eating breakfast daily, limiting eating out at restaurants, particularly fast food restaurants, encouraging family meals in which parents and children eat together, and also limiting portion size. The prevention group also suggested on the basis of analysis and available data and expertise the following behaviors. So eating a diet rich in calcium, eating a diet high in fiber, eat a diet with balanced macronutrients, and also limiting consumption of energy-dense foods. These recommendations were further emphasized and supported in the 2015 report that was in Pediatrics by Daniels and Hassink on the role of the pediatrician in primary prevention of obesity. And also of note, actually just today, the American Academy of Pediatrics and the American Heart Association published recommendations for public policies to reduce sugary drink consumption in children and adolescents. So this topic in particular is something that we'll continue to hear much more on with regards to sugar-sweetened beverages. The recommendations for nutrition in the STAGE treatment approach are very similar to those behaviors that we just talked about for prevention. And so specific nutrition recommendations for stage 1 include consuming 5 servings of fruits and vegetables every day, and subsequently hopefully increasing to at least 9 servings per day as recommended by the USDA. Minimizing sugar-sweetened beverages such as soda, sports drinks, and punches. Preparing more meals at home rather than purchasing restaurant food. Eating at the table as a family at least 5 to 6 times per week. Consuming a healthy breakfast every day. Involving the whole family in lifestyle changes, allowing the child to self-regulate his or her meals and avoid overly restrictive feeding behaviors, and also to help families tailor behavior recommendations to their cultural values. Stage 2 treatment provides a little more structure around balanced macronutrients based on the DRIs, how we talked about earlier, and also more structured meal occasions such as 3 meals per day and 1 to 2 snacks per day. The Academy of Nutrition and Dietetics, formerly the American Dietetic Association, conducted a systematic review on childhood overweight and as a result developed pediatric weight management guidelines. So the focus of these guidelines is on assessment and treatment of pediatric overweight and obesity in a multi-component, multidisciplinary context in children and adolescents ages 6 to 18. These guidelines provide nutrition-related screening recommendations based on behaviors that were shown to be associated with increased or decreased risk of overweight or obesity. The guidelines suggest that there is an increased risk of overweight with increased total dietary fat intake and increased calorically sweetened beverages. There's also an increased risk of overweight or obesity with parental restriction of highly palatable foods, consumption of food away from home, increased portion size of meals, and breakfast skipping. And that there is a decreased risk of overweight with increased fruit and vegetable intake. There were also several behaviors that were found to have inconclusive evidence, such as reported total energy intake, 100% fruit juice intake, inadequate intake of dairy and calcium, parental encouragement or pressure to eat, parental control over child's dietary intake, meal frequency, snacking frequency, or snack food intake, using food as a reward, and also household food insecurity. So there's definitely a need and is ongoing research in these areas to try to understand more. So I'm thinking about these recommendations from the expert committee and from the Academy of Nutrition and Dietetics. There seem to be several commonalities in terms of screening for nutrition-related behaviors as well as prevention and treatment in primary care settings, including decreasing sugar-sweetened beverage consumption, increasing fruit and vegetable consumption, eating breakfast and avoiding meal skipping, decreasing food away from home, and also having positive parent and family involvement in meals, feeding, and behavior change. And when we think back to the dietary guidelines, my plate and those current food and beverage intakes for children and adolescents that we looked at, these recommendations really closely align with that, particularly with regards to decreasing sugar-sweetened beverage consumption and increasing fruit and vegetable consumption. The dietary guidelines in my plate tend to focus more on what we eat as opposed to how we eat. And so as healthcare professionals, I think we have a really important role in helping children and families work on the how we eat piece, particularly around the positive parent and family involvement in meals, feeding, and behavior change. So now that we've discussed all of these recommendations, we can focus on putting them into practice. And so as healthcare providers, our mission is partnering with children and families to make nutrition-related lifestyle behaviors positive, enjoyable, realistic, and maintainable for short and long-term health outcomes, which is all very important, but definitely no short order. Let's first talk about a few resources for screening for nutrition-related behaviors. The first tool is the Family Nutrition and Physical Activity, or FNPA, screening tool. This tool was actually developed as a result of the systematic review by the Academy of Nutrition and Dietetics that I just mentioned, and was a collaboration between the Academy and Iowa State University. And so this tool includes 20 questions and is comprehensive in looking at nutrition, physical activity, screen time, and sleep behaviors that were shown to be associated with overweight and obesity. And so here you can see a little snapshot of the screening tool, and this is just the first 10 questions. The other 10 questions are on the other side of the form. This tool has been validated and has been examined in a number of different research studies. If you're interested in using the FNPA, it can be found at myfnpa.org, and this could be something that could be given to parents to complete at every well-child visit, or it could be something that is integrated into your EHR as part of your screening process. Another screening tool available is the Healthy Habits Questionnaire, and this was originally developed by the Let's Go 5210 initiative out of Maine. And the tool includes 10 questions related to nutrition, physical activity, screen time, and sleep. So this questionnaire is actually included in the Healthy Habits Toolkit, which I'm going to discuss next. That can be found on the Iowa Medical Society website. So now let's move into talking about some of the resources related to counseling for lifestyle behavior change. As I mentioned, recently the Healthy Habits Toolkit for Pediatric Primary Care was released as part of the 5210 Healthy Choices Count initiative here in Iowa. And this toolkit includes a lot of great materials for providers for utilizing motivational interviewing, brief action planning, and education. And so it actually contains education handouts on several different topics that can be shared with patients and families, and includes a provider guide for each of these topics using motivational interviewing and brief action planning. This toolkit is something that could be used with all children and families to have a conversation about lifestyle behaviors, whether that's part of prevention counseling or as part of stage 1 treatment. And so you can find the Healthy Habits Toolkit on the Iowa Medical Society website under the Resources tab and then under Childhood Obesity. So I want to give you a little bit more overview of the toolkit and some of the things that you can find in there. One of the first is that the toolkit provides an action planning flow chart to help walk you through the process of screening, as well as identifying topics of interest for the family, to providing education as necessary, as well as setting realistic goals with children and families. And as I mentioned, the 5, 2, and 0 Healthy Habits questionnaire can be found in here, 2 different versions depending on the age group. The toolkit also includes tools for assessing families' confidence in carrying out their goals, as well as a goal sheet that can be used for documenting and tracking goals if desired. I wanted to draw your attention to a couple specific topics that can be found in the toolkit. Previously, I mentioned one area that is important for us as healthcare providers to help families explore, in addition to what we eat, is how we eat. The recommendations from both the expert committee as well as the Academy of Nutrition and Dietetics mentioned the importance of allowing children to self-regulate eating and to avoid overly restrictive behaviors. So helping children and adolescents learn to pay attention to their internal hunger and fullness cues is really important and part of that. And so one of the handouts in the toolkit includes a resource for a hunger rating scale that can be helpful for some families. And so I encourage you to take a look at that one. Additionally, with regards to how we eat, in discussions with children and parents or caregivers, we can talk about the division of responsibility. And so this is a strategy developed by a dietitian named Ellen Satter and has been supported by the Academy of Nutrition and Dietetics and the American Academy of Pediatrics. The Healthy Habits Toolkit includes some information with regards to this as well. And so with the division of responsibility, parents and caregivers are responsible for the what, where, and when of feeding. So thinking about those eating patterns, where eating is taking place, whether that's at home or out of the home, whether there's screens present or not, and when meals and snacks are taking place or when there is food available. Children are responsible for whether and how much they eat, and so it's important for parents and caregivers to give children multiple opportunities to try foods, and even if they don't like it the first time, continuing to offer it and to try preparing foods in different ways, because it can take a number of different times for children to learn to like different foods. And then also in terms of how much children eat, again, allowing them the opportunity to experience and use their hunger and fullness cues for regulation of eating. Another helpful tool also related to this, just having some of these discussions with parents and caregivers, particularly of younger children, is a resource that's available from the My Plate website called Phrases That Help and Hinder. And these are some helpful phrases that you could share with parents as examples of how to have better conversations with their children around meals and perhaps make meal times less of a battle for some children and families. So a few examples include, instead of saying, eat that for me, instead try saying, oh, this is a kiwi, it's sweet like a strawberry. Or, oh, you're such a big girl, you finished all of your peas. And then try to, instead of saying, is your stomach telling you that you're full, or, has your tummy had enough to eat? Or instead of saying, no dessert until you eat your vegetables, try saying, oh, we can try these vegetables again another time. Would you like to try them raw instead of cooked? So really just encouraging parents and caregivers to think of different wording and strategies that they can use around meals to try to make it a more positive experience, and encouraging children, again, to learn to regulate their hunger, and also to, even pay attention to sensory qualities of food and experiencing food in different preparation methods and things like that. One other resource, if you're looking for more specific information with regards to what to eat or what to specifically recommend for certain nutrients or for servings of the food group, there is a dietary reference intake calculator for healthcare professionals on the USDA website, as well as a calculator of sorts for creating a MyPlate plan through choosemyplate.gov. And both of these resources allow you to enter information for a specific child or adolescent and get recommendations based on their age, sex, height, weight, and physical activity level as well. So I'd like to share a couple more specific resources that you can connect families to for some additional support. We have fantastic extension resources here in Iowa, and I'd like to highlight just two for you to be familiar with. The first is Buy, Eat, Live Healthy, and this is a program offered by Iowa State University Extension Outreach that provides nutrition and cooking education to families with low income who are raising children or youth under the age of 19. Due to the nature of the funding for this program, participants do need to meet certain income criteria in order to participate. The program is available in certain counties in Iowa, and the currently participating counties are shown here. Buy, Eat, Live Healthy consists of 9 core lessons, and program staff meet with participants one-on-one and in small groups. The sessions include cooking, physical activity, discussions, and goal setting. And the lesson topics are based on the dietary guidelines for Americans and MyPlate. And again, cover a variety of content from physical activity to saving money at the grocery store to fruit and vegetable consumption. 2 additional lessons are available for participants that are interested in learning about healthy pregnancies and also for feeding very young children. Every lesson includes worksheets and handouts, physical activity exercises, and as well as opportunities to prepare and taste food. Buy, Live Healthy is just a great opportunity to connect your patients with for nutrition and cooking education. And if they meet those income requirements, the program is available at no cost. For example, if they participate in Medicaid, SNAP, WIC, or free meals at school, they would be eligible to participate in the program for free. To share a little bit more about this program and some of the outcomes, in 2018, 93% of participants reported improved diet quality, 86% improved physical activity, 84% had improved food safety practices, and the average participant reported saving an average of $50 per month on their food bill after completing the program. So if you're interested to refer patients to this program, you can contact Stacia Fanny by email, shown here, and she can help get your patients connected to the appropriate ISU Extension educator for their location. The other ISU Extension outreach resource I'd like to highlight is the Spend Smart, Eat Smart website and app. And so this has over 150 recipes that are inexpensive and easy to prepare. There also how-to videos that feature recipes, kitchen organization tips, and basic food preparation techniques as well. It includes strategies for saving money in different parts of the grocery store, as well as some really helpful meal planning templates and resources. So definitely check this out and encourage your patients and families to check this out as well. So I know I've covered a lot of information today for recommendations and resources, and all of this can be a lot to cover with everything else that you already do for your patients and their families. But just to know that registered dietitian nutritionists are here to partner with you in all of this. So RDNs are the food and nutrition experts that can help translate the science of nutrition into practical solutions for healthy living. Dietitians have a variety of different roles with regards to pediatric nutrition, from counseling with families one-on-one to facilitating a variety of programs and opportunities for learning. Dietitians can also be involved in a number of different partnerships, whether that's through your clinics and health systems or through community organizations. And dietitians also have an important role with policy and advocacy work with regards to child health and nutrition. And across our state and our country, this is something that's really, really important to dietitians. One main resource I'd like to highlight is how to find a dietitian in your community. The Iowa Academy of Nutrition and Dietetics has a resource on its website called Find an Expert. This will allow you to enter your zip code and find dietitians practicing in your area. The Iowa Academy's website is eatrightiowa.org, and there's also a variety of other really helpful information on the website in terms of additional resources, legislative activities, and contact information for the Academy leadership team for potential partnerships and events if you're interested in that as well. As I mentioned earlier, with regards to stage 1 and 2 treatment in primary care, dietitians can play an important role in collaborating on patient counseling, education, and behavior change. And the format of this could really depend on what works best for your clinic and patients. The Alliance for a Healthier Generation in the Academy of Nutrition and Dietetics developed a suggested protocol a few years ago, and this could be used or adapted to facilitate a series of primary care provider and dietitian visits over the course of, for instance, 6 to 12 months. And so this can be found on the Academy of Nutrition and Dietetics website, eatrightpro.org, and there's a variety of resources along with this in terms of care coordination, outlining the different visits, as well as documentation tools for the primary care provider and dietitian as well. There was a fairly large randomized controlled trial a couple of years ago published in Pediatrics by Resnick and colleagues that explored the utilization of motivational interviewing and dietary counseling for obesity in pediatric primary care. And so this is another example of kind of what that could look like in primary care. This study involved 42 practices and 645 patients ages 2 to 8 years. It explored usual care compared to motivational interviewing delivered by a primary care provider or in collaboration between a primary care provider and an RD. And so group 1 involved usual care with annual well-child visits. Group 2 involved primary care providers facilitating 4 motivational interviewing sessions over 2 years. And group 3 involved 4 motivational interviewing sessions with the primary care provider and 6 sessions with a dietitian over the course of 2 years. And so while all groups saw some improvement, group 3, which had involved MI counseling by the primary care provider and RD, had statistically significant reductions in BMI percentile at 2-year follow-up. And so I think this is just one example of the potential that exists for partnerships with dietitians in primary care. Another opportunity is the RD Parent Empowerment Program, and this is available through the Academy of Nutrition and Dietetics Foundation and includes all of the program resources and guides. The program seeks to empower parents to be healthier role models for themselves, their families, and even their peers. The program consists of 4 interactive monthly parent workshops, and there are parent guidebooks that are available in English, Spanish, and Chinese. The program focuses on 8 key behaviors related to nutrition, physical activity, sleep, and screen time. So this program is something that is led by could be led by a dietitian in your community in partnership with your local clinic, whether that's at the clinic or perhaps at a community location. The program has been used in a variety of settings already and has been utilized in a few research studies. The original program evaluation by Hand and colleagues in 2014 included 123 parents in 7 states. And there was a significant improvement in FNPA scores, which is that screening tool I mentioned earlier, from pre to post-intervention. Focus group participants reported behavior change as a result of the program. So if you aren't already connected with a local dietitian in your community, I encourage you to find one and explore opportunities to partner together in meeting the needs of children and families in your area. I also encourage you to connect with the Iowa Academy of Nutrition and Dietetics if you have ideas for projects or events or trainings that you're interested in doing. We have such a fantastic group of dietitians in the state, and we are absolutely here to help you in meeting the needs of children and families. So I want to thank you all for your time and attention today. I hope that you've found some helpful recommendations and resources that you can utilize with families. I've included my contact information here if you have any additional questions. And I've also listed links to some of the websites and resources that I mentioned throughout the webinar in case you'd like to make note of any of those. But I would be happy to take any questions now as time allows too.
Yeah, if you have a question, just go ahead and put it in the type box, to the chat box, and I'll go ahead and answer them right now. There was a question that came in there about how is the insurance coverage for dietitians for pediatric obesity?
Yeah, and that is a great question. I would say, unfortunately, it's not what we would like it to be, and I don't think it's where it should be in order to benefit patients and families right now. And so, similar to most other conditions and for seeing a dietitian, it depends on the insurance provider and likely the amount of time as well. But it's definitely we're working to improve that and hopefully get more coverage so that it could be an easier benefit to access for a lot of families.
We have another question saying, do you know if the Buy, Eat, Live Healthy program will be available in additional counties in the future?
I do not know specifically on additional counties, but I would think too if there is interest from particular counties that they may be willing to consider that. So I would encourage you if that is something that you're interested in and it's not currently available in your county, either contact me or reach out to Stacia that I mentioned earlier or on their website here to see if that's something that might be able to happen. It would be great to have it accessible to more individuals throughout the state.
Great. Well, that's all the questions so far. So thank you all for tuning in, and thank you, Martin, for being the presenter on this webinar and adding great value for the 5210 Healthcare Initiative. Thank you.
Thank you.